Meeting. Yeah. There's the authority meeting plus. You can see us, yeah, I'm How long does it last, the meeting? It lasts for 1 hour. I did remember you mentioned. I think I will. You know what? I mean, Central. In terms of Central. So, okay, so I've been using it. And then she's in. Oh, that's that. So you know Central, you know where they're wanting is not taken. I never planned it. Oh, yeah. Around that. Okay, and that's really well. I work in the outskirts. Like 40 minutes. So I basically one. I live in Nairobi. So Nairobi is also home. It's not as good as being a street home. Really? Yes. It's very cool. Nairobi isn't much more. Good morning. Hi, Peter. Hi.
Hey, hi.
Fine, thank you. How are you?
I'm also doing well. Hello, Prof.
Hi, good morning. Or
Good
good afternoon.
morning. Good morning from Ghana.
How is the feeling of getting back home? Do you miss Cape Town?
Well, I miss Cape Town for the learning, but it's good to be back home.
Yeah, I can imagine.
Yeah.
You look like
It's
you.
good to be back home, so.
You look younger now.
Pardon?
You look younger. And did
Hello,
you
Prof. Wellen.
I think
Prof.
you-
Wellen is on the call, right?
Yes, I tried. I don't know if he can't, if he's here or not. Prof. Welling? I don't know if he's here.
Prof. Welling. Mexico. Okay, this is from
Hello, Dave.
Prof. Welling? Oh, my microphone? Okay. Microphone is muted. I think we're waiting for Prof. Basuna.
Hi, everyone.
Hi.
Hi, I'm Brad. Hi. Brad, are you well?
I think Prof. Welling has a problem with his microphone. He can hear us.
You can hear him, but you can't. You can hear him. You can't hear him.
Can't hear him.
He's on mute at the moment. So, Brad, you're on mute. So I'm wondering, Prof. Basura's not joining us today because he's on call and he's got another. He's had to leave.
Okay.
S- I'm going to send him an email. Can you, Brad, are you able to use the chat function at all?
Okay, sorry, I'm still muted. I'll sign out and re-sign in again. I can use the
Okay,
chat.
all right.
We went to Dizzy Clinic. So Lillian joined the Dizzy Clinic. She
Oh,
enjoyed it.
yes, how was it?
It
was so
nice.
much fun.
Good, yeah. Did you meet the audiology team as well?
Yes, I met them.
Yeah. So,
And-
yeah, that's good. So Greg was supposed to tell me that he would prepare cases, but I'm wondering if he hasn't given the cases to Brad, then we maybe just have to cancel this week because, yeah, that was my understanding. But I'll just check with Brad, Prof. Welling. If he hasn't, then we'll cancel this week and then we can start next week. Because he had to unfortunately leave, but he told me that he would prepare some cases. I haven't prepared anything for today. I had the workplace assessment meeting with the cardiothoracics guys, and I had meetings until 9 o'clock on Wednesday. So I'm just
Oh God, even on your leave,
Yeah.
you have those things.
on my leave. I've had it. I'm exhausted. I'm fed up. I'm going to switch my phone off after this. Yeah. Peter, how are you doing? I see you on the call.
Yes, Prof, I'm doing well.
You're not, your camera's off. We want to see you.
Look at him, he looks younger. He looks so much younger. You
Oh, maybe I don't look any younger than I was.
Okay. Are you doing well?
Yes, Prof.
Okay. Have
Trying
you
to
started
settle
operating
back
yet?
in. No, I haven't started any ear surgery yet. I'm gradually getting myself into the system.
Yeah.
They already
Okay.
got their lists already lined up, so I need to
Okay.
just gradually get my way into everything, but we'll get there.
Yeah. Okay.
I
Well,
think
that's
my
good.
We
think
are
my
Don't
phone
leave
is
it for
working.
don't leave it for too long. Hi,
Sorry,
Brad. Hi.
yeah, sorry, my computers doesn't seem to be letting me in, but my iPhone does.
No,
So hopefully this will be okay.
no problem. Brad, I'd like to introduce Lillian McCo. She's on the meeting. She's sitting next to Divya. You know Divya, one of the residents. So she's joined in on our meetings before. So yeah, Lillian, you started this week?
Yes, I
Is
started
that
this
right?
week.
Yeah, Lillian started this week, so she'll be on the meetings every week. For the first meeting, Greg mentioned that he was going to prepare some cases. He's unfortunately not on the meeting. So I wondered whether he'd by any chance given you those cases or whether we should just postpone this meeting to next week.
He did not give me the cases, or at least I didn't see them. I've been traveling, so he may have tried
Okay.
it. But we could still do some cases. I hate to let a nice opportunity go to
Yeah.
waste. Let me see if I can pull up some cases we could discuss.
Yeah, that would be
That be
great.
okay?
If you've got cases on, preferably just as a start, chronic ear cases, chronic middle ear cases like cholesteatoma or just simple perforation,
Sure.
that kind of thing. That would be great.
Yeah. And the other thing is I do have to leave at 7, unfortunately.
Yes,
I mean,
yes. Yeah,
I'm sorry I got the time fouled up here this morning, but I've got another. So maybe I could just show you one case that we did yesterday. We could talk about it for a minute, and then we can
yeah, that's fine.
regather. Let me see if I can pull my. That would be so helpful if my computer would allow me to join by that, because I can show you the cases much easier on my computer. So Lillian, tell me about yourself while I'm hunting for my for my connection here.
So I'm Lillian Weri Momoko. I'm from Kenya, and I am an ENT surgeon. I have been practicing for the last 3 years as an ENT surgeon, but I've practiced for the last, I think, around 11 years as a doctor. And I'm very passionate when it comes, I love otology, I love ears, and I don't just love the surgical aspect of it. I love the whole ear and hearing care aspect. So I've done quite a lot of work in my country as to pertains policy, putting together some of the like the frameworks and the policies pertaining ear and hearing care. But I think policy, and I love seeing patients, and I love treating ear disease. Yes, and I'm here because I also would love to learn. There's a very big gap in our country, and not just in our country, but in the whole region. We don't have ear surgeons, and most of our patients get stuck. So I'm hoping to learn a lot from Professor Harris, and hopefully I can go back home and teach as many people as possible what I learned from her. And of course, we first people to come down and learn from her. I think she's a great teacher. I've done an observership here before, and I love the program. I loved the program, and I loved her work.
Wonderful, wonderful. It's very nice to meet you. I wonder, did you work in Nairobi, or is that where your work was done?
Yes, I work at Kenyatta University, teaching, research, and referral hospital. So it's a new hospital that is a national hospital that does both teaching and research work in the country.
Wonderful. One of my good friends, one of my good friends, Jim Netterville, has spent quite a bit of time in Kenya doing outreach work. He's a head and neck surgeon, so maybe you didn't interact with Jim. I don't know if you know him or not, but he's a good friend and colleague of mine. Do you know Jim?
Yes, actually, I know him, and if you meet him, you can tell him Lillian from Kenya said hi. He's a good friend too. He's a mentor. When he's come for one of the camps, and we did some head and neck work and also some hearing screening work in Malindi.
Oh, good, good. Yeah, he's a true gentleman and a wonderful person. I really like him. I'm still having trouble with my laptop for some reason, and so
No,
I
that's
might not really easily be able to show you this case from yesterday. There was a case of a young woman, 37 years old, who had prior tympanomastoidectomy for cholesteatoma. And then I had operated on her about 18 months ago for recurrent cholesteatoma. And she came in really asymptomatic to the office a couple of months ago, but had some evidence on her exam that maybe she was developing a recurrence of her cholesteatoma. She had a bit of a retraction pocket. She had quite a good outcome from her ossicular reconstruction, so she had a mild conductive loss, but that hadn't really changed. But I was suspicious that maybe she was getting a recurrence, so we did a CT scan, which I hope maybe I can share with you. I don't know if this will work, but let me try this anyway. If I can get it on my screen, I'll show you with my iPhone. If it's too poor of quality, we'll drop it, but let me see if I can show it to you. The other thing that I did that becomes an issue, and maybe you could tell me how you deal with this. Certainly, in a revision mastoid or in a prior complete mastoidectomy, it's possible on a CT scan to see soft tissue in the middle ear or mastoid, but determining whether that is cholesteatoma or scar tissue is sometimes a bit of a challenge. And I realize that MRI is not always an option, but it can help us detect the difference between scar tissue and MRI and cholesteatoma. So, how do you all deal with that if you have someone you're suspicious of cholesteatoma and you do see soft tissue on a CT scan? How do you proceed in that fashion? Lillian, how would you handle that in Kenya?
Okay. So this is a patient who definitely had a cholesteatoma removed. So we're thinking about someone who would be having a recurrence of ear disease. What I would first want to find out is maybe from the previous history, if she's a patient who had a bilateral disease or unilateral disease, and that in my thinking would be because of the development of the retraction pocket in the new retraction pocket. Maybe they have some eustachian tube disorder that is causing the retraction. That probably would be the start to find out if now the retraction pocket is because of the cholesteatoma or if there's any eustachian tube dysfunction causing the retraction. The other thing I would also like is some additional history from the patient, especially with the symptoms on CT scan. If you're having some opacification on CT scan, so does this patient have any ear discharge? Or the ear has been dry throughout this time? Has there some sort of pain? And probably even more into the characteristic of the discharge. And then perhaps get a closer look, put in a scope when doing the examination to examine and see if there is some debris, because most of the time cholesteatoma is
is a clinical diagnosis. So you want to get the history. You want to also get a look and see whether there's any visible sign, if there's any remnant squamous debris that is accumulating in the retraction pocket, or if it is just a plain retraction pocket.
Yes, yes, those are all excellent questions, excellent points. So she does not have disease in the left ear. She does not show any retraction of the left eardrum. The examination with a microscope is probably what led me to have concern because of a little decreased mobility and retraction above the cartilage that had been placed in the eardrum on the right. We do often have discharge granulation tissue when there's recurrence of cholesteatoma. She did not have any. She actually had no complaints, which is unusual, I think. I'm going to try to show you my screen here and see if this works. I don't know. Let's see if I can do this. Okay, let's see. That's not in focus, is it? It's poor focus, I wonder. It doesn't appear to me to be in focus. Can you see the CT? But it's very fuzzy, right?
Just click on the
We can
center.
see the CT, but it's very fuzzy.
Yeah.
If you
If you
press
put
on
your-
on your screen, maybe it might zoom onto.
Will
Let me
focus.
try. Let me try a different way here.
You just go straight back to the way you're going and then just press on the screen itself.
What if I do it this way? Is that better? No. Does that show it any better or not? Is that still fuzzy?
Yeah, it's still fuzzy.
Yeah, still fuzzy.
I wonder why my camera won't focus on that. Try one other thing here. No, I can't get it to focus on it for some reason. I'm just having all sorts of technical problems today. I just can't seem to find a way around this. Oh, well, let's see. Sure wish I could share my screen with you. I'm going to try one more time to sign on. I did sign on to my computer once more, and it's having the same problem. Maybe my software needs to be updated or something, because as soon as I sign in, it locks me out. It does not let me show. I'm going to try once more here. Yeah, I need to. I re-signed my
Maybe
computer, but
Brad, maybe while you seeing if you can get that screen to work, I can ask Divya is going to be writing exams soon, and
all right.
and so just to ask Divya, which what imaging would you use to see if there's recurrent cholesteatoma? Yeah.
A non-EPI diffusion weighted image MRI.
Okay, and when do we typically use that imaging?
So after 1 year, when we're suspecting there could be recurrence or residual cholesteatoma.
Yeah, and in which cases? That's what I'm trying to ask.
Oh, so if so especially when it was a difficult, we didn't address the disease completely. If we find on inspection that there's a sump, the bony ridges, or the epithelium has not well epithelialized in the cavity. If there's a perforation or an inadequate meatoplasty.
Okay, but those are reasons for leaking cavities, right? And usually in those patients we suspect recurrence. But what I'm asking is, what are the indications that we usually use for using a diffusion weighted non-EPI diffusion weighted MRI scan? Lillian?
Okay, so the diffusion weighted MRI scan is mainly indicated in two cases, not just those two, but mainly you want to do it when either you're not able to the patient is not a good candidate to go back to theater for re-examination to try and find out if there's a remnant cholesteatoma and if what
Recording in progress.
that Divya is talking about, that is things like edges. If the patient is not a good candidate for relook surgery, one. And secondly, you also want to do it in candidates who you're not so sure whether it is granulation tissue like the patient that has just been presented. So you're not sure whether there's a recurrence or granulation tissue, so that the patient is not a typical cholesteatoma patient. You also want to do that to rule it out. And then any other indication that could be any patient that maybe the patient themselves feels like they are not comfortable to consent for a relook surgery. That is also another you want to do at that time.
So all of those are correct, but remember, you've said it yourself, cholesteatoma is usually a clinical diagnosis. Okay, so when you've taken the canal wall down, you should be able to see whether or not there's recurrent disease. So the answer to that is usually when you've kept the canal wall up, like in a canal wall mastectomy. So you can either follow up imaging, or you can take the patient for a relook. But that you can't obviously easily see residual recurrent disease because you've kept that canal wall up. And then in another indication, if you've obliterated the ear completely, like you've done a subtotal petrosectomy, or you've done a mastoid obliteration, where you actually just can't actually visualize whether or not there's recurrence, those would be indications. So I think it's just to bear that in mind. So frequently I see in the clinic, people are asking for non-EPI MRI scans for people who've had canal wall down mastectomies, and that's not the right indication. So if there's cholesteatoma, you should be able to see that clinically in a canal wall down. Okay.
Are you able to see the CT scan now?
Are you almost ready, or?
I don't know. Can you see the CT scan now? Can you see my
No, we see a
screen?
screen. We see a screen, which is the Zoom screen.
Okay. Let's see if I can change.
We can see your screen, but we see a Zoom, the Zoom launch meeting page.
Okay. Let's see if I can switch these. Can I see a background?
Yes, yeah, I will see the background.
I can see it on my. I'm gonna try detaching the screen if that helps. Now can you see the screen?
Yes. Yeah, we see it. Oh, it went. We saw it for a few seconds and then it went.
Now can you see it? Oh. Can you see anything now?
No.
No, we literally saw it for a few seconds and then as you did something and it went.
Well, maybe we should continue this next time. I'm sorry.
No, that's absolutely fine. I'm going to continue ask you. You have to run off soon, Brad, I believe. So maybe if it's okay with Divya, do you guys want to continue with a few more questions? Is that okay? Yeah. So yesterday we had in theater, Brad, we had a patient who had revision mastectomy, and the indication for surgery was a continuously discharging ear. And I asked Divya, I asked you this question yesterday, maybe I can put it to Lillian. What are the causes of a discharging ear after mastoid surgery? So chronically discharging ear after patients had mastoid surgery.
So the causes of a chronically discharging ear after mastoid surgery, one, you can have an incomplete mastoidectomy, where you have a surgery that was done and all the diseased ear cells were not removed. So you have some remnant ear cells. Secondly, you could have improper suturization. So while doing the mastoidectomy, the suturization was not done well, and there was some bony overhangs left, leaving some edges for probably recurrence of disease. Sometimes you can have incomplete removal of disease. So you have probably you have like cholesteatoma and you're not able to remove the entire cholesteatoma sac. So you have remnant disease that remains there. Sometimes you can also have infected cavities, subchronic infections. Sometimes, if, for example, you have mastoiditis due to disease like tuberculosis, you don't treat it or you don't get it after you do your culture. Tuberculosis and such diseases can give you a prolonged discharging ear even after mastoidectomy. Also, you could also be having you could have disease recurrence. It's quite common in patients who have cholesteatoma, especially if you treat and then you have more of the tissue, the re-epithelialization going back. And sometimes you can also have a granulation tissue that persistently remains infected. I don't know if there is more, but
Yeah. I think
yeah.
Brad, we can see your scan now.
Wonderful. You mind if I'll just run through it real quickly? Maybe if somebody could describe it. Peter, are you still on? Do you want to describe the scan? I'll just zoom through it slowly here. So,
Yeah, maybe we can ask someone to comment. So Divya, do you maybe want to, Divya's taking exams next?
So this is an actual view of the right side of the temporal bone, where we can see a polynomatized, a previous mastoidectomy has been performed on this child. There's opacification in the mastoid cavity and opacification in the middle ear with remnant ossicles.
This is actually the titanium port that was placed, but there is the malleus somewhere there. Yeah. What do you think about the lining of the mastoid?
Yeah, it's thick. It's a thick opacified. So it could be granulation tissue.
And aeration in the middle ear.
It's not well limatized.
Yeah. Very thickened tympanic membrane. We did place some cartilage in it last procedure. The epitympanum is quite full of soft tissue.
Mm.
And for comparison, let me see if I'm able to show the other side just at the same time, since it's a better looking mastoid.
And if I can comment that when you ask what do you think of the linings on the posterior cerebellar plate, that looks very smooth, but then there's that scalloping anteriorly, and that's very scalloped, which usually I think of cholesteatoma when I see that kind of edge. So even though, you know, you can't make that diagnosis on a scan, on a CT scan, but when I see that, I usually think, well, there's possibly cholesteatoma there because it's too, you know, it's got that scallop kind of edge to it.
Mhm. Other side, much better looking oscars with the ice cream cone. Head of the malleus, body of the incus, horizontal, labyrinth and segmentation, the endolymphatic duct, posterior canal. I'm going to quickly jump over to the diffusion weighted because I've got to jump off, but let me show you what we saw on the MRI scan. Maybe shows best on this corona weighted image. You see this
Oh, wow.
bright area? That was all cholesteatoma. So we revised from mastoid yesterday, and the question is whether to do a canal wall up or canal wall down. This was her third procedure. But because the cholesteatoma had not eroded into everything else, we did not take the canal wall down. We reconstructed with a little more cartilage in the eardrum, put in a new prosthesis, and we're giving her one more chance. Looks like she's got something going on in her sinus there too, but probably just a little bit too. I apologize for all the technical glitches this morning. I will be
That's
on
fine.
time and have my computer working next time. But for now, I better sign off. So thank you.
Yeah,
Nice to meet you,
very
Lillian.
nice.
Welcome aboard. Peter, good to see you. Thanks.
I hope you have a good weekend.
Thank you.
So Div, if you guys can stay on, I'll continue asking questions. So Lillian, so you mentioned so firstly, when you said incomplete mastodectomy, you want to try and avoid the term incomplete mastodectomy. So with the mastodectomy, what we usually encourage is you either kept the canal wall up or you kept the canal, you made a canal wall down. But what you mean was unexonerated air cells. So what is the unexonerated air cells? How does that lead to a discharging cavity, do you think?
So because the principle of mastoidectomy is when you have the air cells, mucosa infected, and that is what continuously discharge.
Okay.
When you do the
So
mastodectomy,
it's the mucosa.
you're removing the mucosa,
Yeah.
so the
Okay.
mucosa. Yeah.
Yeah. So the idea behind that is that it causes, instead of a cavity which is very nicely epithelialized, you now have a cavity which is mucosalized. So that's one of the technical things that can lead to a mucosalized cavity, which leads to a discharging ear. And what are why would a cavity that's not well saucerized give rise to a discharging ear?
So the edges, the edges that are left are usually potential spaces for cholesteatoma to start forming. So you want to leave no hiding spaces or no spaces for accumulation of squamous debris. So that's the point of saucerization.
There's another reason for that, Divya. What's the other reason? What's the other reason that incomplete? Just looking for something that I can write on that I can show you guys. It's very difficult to do this online. What's the reason for if you haven't saucerized a cavity, what's the reason that continues to discharge, that's prone to discharge?
Also, when re-epithelialization is happening, when you have it, it kind of skips, instead of it re-epithelializing on top of the bone, it kind of leaves a potential space.
A sump.
Like a, yeah.
What do we call that? A sump. So you get a sump. Yeah. So that's what, so that's just so that you understand, you know, when you list these things, that you're actually thinking about why, you know, because it's often the textbooks cite them, but it's just so that you think about why that would actually lead, you know, what's the reason behind this, it leaves a sump. And the other reason is the more edges you have, the bigger the cavity. And the bigger the big mastoid cavities are problematic because they don't epithelialize well. So they can end up mucosalizing as opposed to epithelializing. Or when they do epithelialize, they fill up with debris that gets infected. So a big cavity, and a big cavity doesn't ventilate well. So every time that person gets into a shower, or, you know, they're meant to avoid water at all times, but it's nearly impossible to do that. But every time they do make contact with water, it just gets infected. So when you leave your edges sharp, you end up with a bigger cavity, and that's more prone to discharging. Okay, so, and it leads to some formation. So those are the two things that you mentioned. What are the other things that leads to some formation, or that leads to a sump in terms of your technique with a canal wall down?
You need to lower the facial ridge.
Facial ridge, if you have a very high facial ridge. Suraj, do you know what is meant by a facial ridge?
Facial ridge is the bony prominence above which the facial nerve
Sorry, I
runs.
can't actually hear where you're sitting. I think you might be sitting a bit too,
Facial ridge is the bony prominence above which the facial nerve runs in the tympanic
bony
cavity.
prominence. Wait, say that again.
Yes.
Yeah, it's the bony ridge. It's the bony ridge above which the facial nerve runs in the tympanic acid segment of the facial nerve. In the
Yeah, I
tympanic.
can't hear that. So what is the facial ridge?
It's a bony prominence. It's a bony prominence above which the facial in which the facial nerve runs.
Okay, but isn't that the fallopian canal? Devia, what's the facial ridge?
So it's basically when we lower the
Yeah, exactly. The
canal.
facial ridge is something you create when you're doing a mastodectomy. When you're doing a canal wall down, that bone above the facial nerve is something that you create as a surgeon. It isn't there. It's not an anatomical ridge. It's not like it's there. It's, you can't describe it on a scan unless the patient's got a canal wall down mastodectomy, but that ridge you created, right? So so if you've got a high ridge, you end up with a sump. Whereas if you lower the ridge and you go right onto the facial nerve, there's a bigger chance that that cavity will epithelialize well, and that you won't have a sump. And that's why patients with a well lowered facial ridge, their cavities are far more dry and they do better post-op in terms of healing. So you mentioned the inadequate meatoplasty. I think we've touched on already. Suraj, you understand how an inadequate meatoplasty can lead to a discharging cavity?
It doesn't allow the drainage to flow well because of
It's difficult to clean.
Yeah.
They're difficult to clean, and you get a retention of debris, and if it's difficult to clean because you've got a small meatus, we see them all the time, right? You get those people that you just can't clean them well in clinic. Okay. Lillian, can I ask, a patient with for revision surgery, mastodectomy, what are the key things that you would look for on a scan to know whether or not you can operate safely?
So when you have a patient for revision surgery, you first want to find out one, from the previous surgery, if it was a canal wall up or a canal wall down. If it is a canal wall up, you have your landmarks very well, especially as pertaining the facial nerve. Secondly, you want to look at the cause of the facial nerve. Perhaps in the previous surgery, maybe there is you look for any dehiscence, look for any, you check to confirm that the facial nerve is also in the right place. And then thirdly, you want to look at the tegmen. You want to look at the tegmen, how it is, if it is a low-lying tegmen,
if there's any dehiscence again on the tegmen. And finally, you want to look at the position of your sigmoid sinus. So you want to
Okay.
check if it was previously exposed or not, and what kind of a sigmoid it is, if it is an anterior one, or if it is a prominent sigmoid. And finally, always you want to know the position of you want to look at the hypotympanum and the position of the jugular bulb, if it is a high one or a low one. Sometimes, especially if the patient had a canal wall done in the previous surgery.
Yeah. And then, yeah, that's all correct. And I think those are all important things because those are factors that could have been exposed or structures that could have been exposed during the first surgery, right?
Yes.
Okay. Deciding what factors do you how do you decide whether or not to do a canal wall up or canal wall down mastectomy, Suraj? What factors do you take into account?
The disease factors, which is the extent of the disease itself.
Yeah.
And yeah, so that's one factor. You'd also take into account patient. So it would be the extent of the disease. It would be about the aeration and aeration of the mastoid cavity and the ventilation of the mastoid cavity. So poorly aerated cavity, you'd want to do a more extensive disease, more extensive operation.
So Suraj, don't confuse aeration with pneumatization. Okay, so you're saying aeration, but you can have a well pneumatized mastoid cavity that's poorly aerated, but that doesn't mean you're going to do a canal wall down because that could just be fluid.
Yeah.
So when you understand the difference, right? So I understand what you're saying, but remember in an exam, the examiner doesn't know you and doesn't necessarily know that you know what you're saying. So I know that you know what you're saying, but an examiner who doesn't know you won't know that. So you want to make sure you get your terminology right. So pneumatization refers to, is it well pneumatized or is it sclerotic? So sclerotic mastoid, you're more likely to take the canal wall down. Why is that?
Because it is so.
Divya, why would you take down a canal? Sorry, yes? Why would you take down a canal wall down if it's sclerotic? Anyone can answer.
Because I think that if you have a sclerotic mastoid, it could still be holding disease within it, which you just can't.
No, that's not the reason. Anybody? Lillian?
So when you have a sclerotic mastoid, you want to do a canal wall down because you want to make sure that you create a cavity that is very easy to open, and also a sclerotic mastoid is highly likely to have remnant disease. So you want to have something that you can continuously keep cleaning and something that you will have proper.
Yeah, that's actually not the reason. The degree of pneumatization of an ear is a reflection of the eustachian tube function. So if you have a very sclerotic mastoid, chances are that eustachian tube was not working well. You had eustachian tube dysfunction, which led to a sclerotic mastoid. And where you've got poor eustachian tube function, the risk of recurrence is higher. And so for that reason, you often take the canal wall down. The other reason is, that's the main reason, but if you've got a very sclerotic mastoid and there are no cells, by taking the canal wall down, you're still not going to end up with a large cavity because usually the disease is fairly limited. So even if you take it down, you still have a very small cavity because of the disease. The disease can't spread that much because it's a very sclerotic mastoid, but the risk of recurrence is higher if you leave that canal wall up. Okay, does that make sense? All right. What are the other factors that determine the canal wall up, canal wall down?
So they can just be patient factors, and one of the patient factors would be the follow-up of the patient. So if someone that you expecting wouldn't follow up well, you rather do a canal down mastectomy, because canal up needs regular cleaning. Yeah, that's one other factor. Then regarding the
Yeah. Divya?
Complications, if the complications like extent of
Yeah.
disease.
Complications like what?
So, so if there's a so facial nerve dehiscence or sigmoid sinus thrombosis or labyrinthitis, petrositis, or yeah.
What about a fistula of the lateral canal? Take it up or you leave it down?
Take it down.
Take it down. Okay. What are the other indications for canal wall down? So you mentioned disease factors, extent, the pneumatization. You mentioned compliance issues. Yeah, what else?
Ventilation.
Lillian actually mentioned it, not meaning to mention it under that, but you mentioned a reason.
The cleaning.
Yeah, not what I'm thinking of. What anatomical factors would make you take the canal wall down?
Or some patients have a really protracted, a very small mastoid.
No. Very anterior sigmoid.
Oh,
anterior.
If you have a very anterior sigmoid, there's not enough space to keep the canal wall up, and you can only take it down. So those are anatomical factors, and that you have no choice there but to do a canal wall down mastectomy because you're limited by your anatomy. Sometimes the sigmoid is sitting right in the posterior canal wall. Okay. All right. What else? Divya?
Poor eustachian tube function. So yeah, that we know from the history.
Yeah.
And if there's residual cholesteatoma, and we know that we need to. So for example, if there's lateral semicircular canal, that we don't want to peel off.
Yeah, but that's a complication like a fistula. I think you've mentioned everything. Just remember, in the exam, sorry, I know I keep coming back to that exam, but it's just because you're preparing for it. You have, my battery's going to go soon. You have very little time. Okay. So you literally have got to mention those things like that. Okay. So you've got to say the patient factors, the disease factors, and the patient factors are patient who's not fit for anesthetic, patient who's got poor compliance, a patient who says, don't forget the other patient factors are, if you have an athlete who says, I swim, you're not going to do a canal wall down mastectomy for easily unless he's got other reasons that you should be taking the canal wall down for. Does that make sense? Obviously, if you've had a complication before, you're going to go, sorry, I can't. But ideally, you want to try and keep that canal wall up, or you want to try and have a smaller cavity as possible. And then other things to think about is, if it's your institution, that might sway you if you're limited in terms of follow-up for imaging, and you had to take the patient to theatre, but you're also limited for theatre time, and those are all real factors, then it might persuade you to do a canal wall down, okay? And then you obviously want to mention anatomical factors. So things like if you had a very low-lying or sclerotic tegmen, or you had a very anterior sigmoid, there's no space there to keep that canal wall up. So you're going to have to take it down. So then you would deal with front to back, and you're taking down the canal wall automatically. Okay. And then obviously the other things are, did I leave anything out? Presence of previous complications. So presence of previous complications. So if the patient has had fistula, intracranial abscess, or anything like that. So those are, you want to be really quick about your answers and have that very clear in your head. And the thing about that exam is they ask for very common things. They're going to ask you on exactly this. They're not tell me about von Recklinghausen's disease. Nobody's going to ask you that in an exam, but they will ask you these questions. What would you do if this patient comes back? How would you manage? Like we discussed yesterday, looking at a scan and instantly saying, this is a revision mastodectomy. I would be concerned about the sigmoid that's decent, the facial nerve is decent, because then they know you're a safe surgeon. Okay, so you have to practice that. And I think what we're going to do for the next 3 or 4 meetings, I think we're going to have cases. Okay, so that you guys can talk through cases so we can see where the gaps are. Is that okay? Yeah? All right. I'm going to leave you there, guys. Have a good weekend. And just before I go, Divya, I don't know if it's going to be Eid on Thursday or not. There's a good chance it may be.
Okay, so I'll, ooh,
Have fun before we die.
let me show you.
Let's do 10 minutes. Questions.
No, because we don't know, we never know, but I thought it might be. But I mean, you're the miss.
These are students, you're allowed to make mistakes. Okay, we are students, but.
Hi, Prof. Hi, yes, I can hear you. Yes. Okay, yeah. So